Welcome to this explainer on Pheochromocytomas and Paragangliomas. We're going to tackle this incredibly dense, high-yield material as a high-stakes clinical case study tailor-made for your internal medicine wards. We're talking about catecholamine-producing tumors that sprout from the sympathetic or parasympathetic paraganglia. And let me tell you, these tumors are notoriously tricky to pin down.
So let's just dive right in and put you squarely in the exam room. Picture this, your 40-year-old patient rolls into the clinic with what looks exactly like severe acute anxiety. Their heart is practically beating out of their chest, they're sweating right through their clothes, and their blood pressure, it is completely through the roof. Now you have to ask yourself, is this just a really bad panic attack? Or are we looking at the great masquerader? Because misdiagnosing a full-blown catecholamine crisis as just standard anxiety or essential hypertension, well, that can be a fatal mistake.
To navigate all this, we definitely need a game plan. Our clinical workflow today goes like this. First, we'll meet the masquerader. Then, biochemical diagnosis. After that, locating the tumor, walking the surgical tightrope, analyzing the genetic fingerprint, and finally, metastasis and follow-up. Let's get to it.
Starting off with Section 1, Meet the Masquerader, Clinical Presentation. We really need to figure out how to recognize when a seemingly routine symptom is actually a glaring red flag.
When you're assessing this patient, you want to aggressively hunt for the 5 Ps. First up, pressure. We're talking hypertension that can be either paroxysmal or sustained, which happens in about 90% of these folks. Then there's pain, usually a really severe pulsating headache. Next is perspiration causing drenching sweats, followed by palpitations from all that tachycardia. And finally, pallor. Now really notice that, it's pallor, not flushing. The massive surge of epinephrine and norepinephrine causes such severe vasoconstriction that it actually leaves the patient looking extremely pale and intensely anxious.
You might be keeping an eye out for the classic PHP triad: palpitations, headache, and profuse sweating. But here's the catch. Only about a third of patients will actually show up with all 3 at once. That being said, here is your absolute golden rule for the wards. If you do see that PHP triad and it's paired with hypertension, you treat that as pheochromocytoma until proven otherwise. No exceptions.
All right, moving into Section 2, Biochemical Diagnosis, Diagnostic Traps. Because once you suspect this masquerader, you've got to prove it, and you have to avoid some major historical pitfalls while doing it.
Okay, listen up, because this is crucial. You absolutely must order plasma-fractionated metanephrines. Why? Well, these tumors continuously leak metanephrines into the blood, whereas their actual catecholamine release fluctuates wildly. Because of this constant leak, plasma metanephrines give you an incredible sensitivity of about 99%. It is definitively your first-line test. Now, you might remember the 24-hour urinary VMA test from your old textbooks, right? Well, forget it. It only has about a 64% sensitivity and is completely obsolete today. Seriously, don't fall into the trap of ordering it.
So, the big takeaway here is that if you draw those plasma-fractionated metanephrines and the lab comes back at more than 3 times the upper limit of normal, bam, your biochemical diagnosis is practically locked in. You have definitively confirmed the excess.
Next up, Section 3, Locating the Tumor. Imaging strategies. We've got our biochemical confirmation, now the hunt is on to find exactly where this thing is hiding.
You're typically going to start this hunt with a contrast CT, and you're specifically looking for a lipid-poor mass. To put that into perspective, on an unenhanced scan, a standard adrenal adenoma is usually lipid-rich, measuring under 10 Hounsfield units. A Pheo, on the other hand, is going to measure greater than 10 Hounsfield units. But if you're dealing with a pregnant patient or a child, an MRI is a really fantastic alternative. Because these tumors retain so much water, on a T2-weighted MRI, they literally glow. It creates this highly recognizable classic T2 light bulb sign. It's really something to see.
Now, as you locate the tumor and start putting together your overall assessment, I need you to do me a favor. Take that old medical school rule of tens and just throw it right out the window. You know the one, 10% bilateral, 10% extra-adrenal, 10% malignant. Yeah, scratch that. We now know that up to a quarter, 25% of these tumors are actually tied to germline mutations, and up to 15% are metastatic. Knowing this completely changes the game for how we manage these patients.
Moving to Section 4, Surgical Tightrope, Preoperative Pathway. So, you've found the tumor and you're consulting surgery. Great, but prepping this specific patient for the OR is an absolute tightrope walk. You cannot just wheel them right in. To safely get them through this preoperative phase, you have to follow these exact steps in strict chronological order to get their blood pressure consistently below 160/90. Step 1. Institute an alpha blockade, usually with phenoxybenzamine, starting a good 10 to 14 days before surgery. Step 2 is absolutely critical: volume expansion. See, because these folks suffer from intense chronic vasoconstriction, their total blood volume is actually shockingly depleted. When you hit them with that alpha blocker, their vessels suddenly dilate. If you haven't aggressively hydrated them with a liberal high-salt diet and IV fluids, their pressure is going to completely tank. Finally, step 3, you add a beta blocker, something like propranolol, just to keep that reflex tachycardia in check.
And honestly, I literally cannot stress this enough. This right here is the single most dangerous trap on the internal medicine wards. Starting a beta blocker first is an absolute never event. Think about the physiology. If you block those beta-2 receptors, which are normally providing at least a little bit of vasodilation, you leave that massive surge of catecholamines completely free to hammer the alpha-1 receptors, totally unopposed. You will instantly trigger a catastrophic, life-threatening hypertensive crisis. It's a disaster. Always, always, alpha before beta.
All right, so assuming you've prepped them perfectly and the surgeon successfully gets the tumor out, pathology takes the wheel. And they're almost certainly going to confirm your brilliant diagnosis when they look under the microscope and see this classic Zellballen architecture. That's German for balls of cells. Basically, these little nests of chromaffin chief cells all wrapped up snugly in a supportive network of sustentacular cells.
Next is Section 5, the genetic fingerprint, universal testing. The surgery might be over, but our job sure isn't. Because of that modern rule of tens we talked about, every single one of these patients now requires universal germline panel testing. No skipping it. There are some major, highly board-relevant clinical clues you got to watch out for here. As I mentioned, universal testing finds a mutation in roughly 30% of these patients. You really want to pay special attention to the fascinating paternal imprinting rules for genes like STHD and MAX. What this actually means is wild. If a patient inherits the mutation from their mother, they won't even develop the disease. It only causes tumors if it's inherited from the father. Also, don't forget to let your physical exam guide you. If you spot retinal or cerebellar hemangioblastomas, that points straight to von Hippel-Lindau. On the flip side, if you see café au lait spots and Lisch nodules, that absolutely screams neurofibromatosis type 1.
Now, what if your patient's genetic panel comes back with a RET proto-oncogene mutation? Well, you can use this breakdown to rapidly distinguish MEN2A from the far more aggressive MEN2B. Both syndromes feature Pheos and medullary thyroid cancer, right? But MEN2A is going to present with primary hyperparathyroidism. MEN2B, however, skips the parathyroid issues completely and instead presents with mucosal neuromas on the lips and tongue, plus a classic marfanoid body habitus. And here is a massive clinical pearl for you: always, always exclude and treat the Pheochromocytoma before you even think about sending a MEN2 patient for a prophylactic thyroidectomy.
And what if their panel reveals an SDHB mutation? Well, I want you to sear this specific number into your brain. Roughly 33% of patients with an SDHB mutation are going to develop metastatic disease. Out of all the genetic clusters, this one carries the absolute highest malignancy rate, by far. Which brings us to our final section, Section 6, Metastasis and Follow-up, Lifelong Vigilance. Let's talk about managing advanced disease and mapping out that long-term care. For the 5 to 10% of folks who unfortunately do develop metastases, which usually spread via the blood, right to the lungs, bone, or liver, our entire strategy has to shift. And please note this carefully. In these specific tumors, malignancy is defined only by the presence of metastases. You can't diagnose it just by looking at cellular atypia under a microscope. When it comes to treatment, if the metastases light up and take up MIBG on a scan, we hit them with targeted 131 iodine MIBG therapy. If they have an SDHX mutation, dotatate therapy is a fantastic option. And if we need to go with traditional chemo, the Averbrook CVD regimen, that's cyclophosphamide, vincristine, and dacarbazine, is going to be your first-line mainstay.
So let's bring it all back to your patient in exam room 1. They came in with a terrifying hypertensive crisis. You expertly diagnosed them using plasma metanephrines, you meticulously prepped them for the OR with alpha and then beta blockers, and they made it out of surgery totally safe and sound. But as their internal medicine doc, you really have to ask yourself one final critical question. Are they truly cured for life?
The harsh reality? No, they aren't. Believe it or not, even completely sporadic cases carry a 15% recurrence rate, and sometimes it pops up more than a decade later out of nowhere. Because of this, sporadic cases need annual biochemical screening for at least 10 years. And for those with hereditary mutations, they are locked in for lifelong surveillance. The great masquerader is basically always waiting in the wings. So the real question is, when it inevitably tries to make a comeback, will your clinical vigilance be sharp enough to catch it before it catches your patient?